I'm going to talk a little bit about what's happening in Washington. Not necessarily a very pretty picture. Lots of challenges that we're facing. So hopefully this will work. I'm not sure if I point, yeah, there we go. Start off by just a little bit of background on NCOA. We started back in 1950. We're actually kind of like the grandparent of the Aging Network, nonprofit group in Washington, D.C. We're particularly focused on older adults who are vulnerable and disadvantaged. So that's the group that we are most interested in serving and advocating on behalf of. And not only those older Americans, but also the community organizations that serve them, like GRADD. We do a lot of work in a whole host of community services areas. I mentioned the One Away campaign and benefits access. There's also a great deal of work that we do in areas that GRADD has a direct financial interest in with regard to programs like AmeriCorps, programs under the Older Americans Act, health insurance assistance and counseling programs, etc. So I want to talk a little bit about those. But I first want to start by talking about, I'm not only here because we want to support the great work that GRADD's doing, but Kentucky is one of the most important states in the nation when it comes to what's happening in Washington and what's happening on senior issues. You have two extremely influential senators, not only Senator Paul, who is on the committee with jurisdiction over Older Americans Act reauthorization. As you know, the minority leader of the Senate, Senator McConnell, Representative Rogers, who is the chairman of the Appropriations Committee that has control over purse strings, Representatives Whitfield and Guthrie on committees that have jurisdiction over Medicare and Medicaid. A very important group, which is why Kentucky really is one of the most important states in the country when it comes to these issues. What I've learned over the past 25 years of advocating is it's not easy. The devil's in the details. The challenges that we're facing now are challenges not only that individuals are facing economically, but organizations that are trying to serve those individuals are facing, and challenges that the country's facing. We do need to get our economic house in order. We do need to find ways to reduce the deficit. And those aren't easy. It has to be bipartisan. If it's not bipartisan, it's frankly not going to happen. So it's really important that we all recognize that we need to work on both sides of the aisle to find solutions to the problems that we've got. And one of the things that we've found in doing a lot of kind of town hall meetings and senior centers with people from all across the ideological spectrum, Republicans, Democrats, etc., is kind of stick to the facts. I like to start some of the presentations we've done on health reform with a picture of Joe Friday, who some of you may recall from the TV show Dragnet, who used to say, "Just the facts, ma'am." And I will tell people that, you know, we're all entitled to our own opinions, but we're not entitled to our own facts. So one of the things that I think is really helpful is to try to be factual, try to provide good information, try to provide good data, because the devil is in the details, and we need evidence to show that the programs that we care about work. It's a real critical time right now for the federal budget and for senior programs. As many of you know, back in August, big debate over the debt ceiling. A compromise bill was passed that's basically two parts. First part, which is pretty straightforward, $900 billion in reductions in discretionary programs over the next 10 years. And discretionary as opposed to mandatory, one of these Washington-speak distinctions. Mandatory programs are typically thought of as entitlements, like Medicare, Medicaid, Social Security. Many of them earned benefits by paying payroll taxes for the lifetime. Discretionary programs are things that need to be appropriated every year. So it's not only defense, it's also a lot of the programs that we care about with regard to Older Americans Act, with regard to housing, with regard to LIHEAP, a variety of senior programs. So the first reduction came in these discretionary programs. Now we're into round two. We're into the debate. Senator Paul referred to this deficit reduction committee. Some, call it a super committee. 12 members, half House, half Senate, half Republican, half Democrat, who have until Thanksgiving to try to come up with a plan. And then the Congress needs to approve it by Christmas. If they don't, an automatic cut's going to take place. that also is on discretionary programs. Revenue's not in that automatic cut. Mandatory programs, a small piece of it. Medicare provider payments can be reduced, but basically it exempts Social Security, Medicaid, and cutting Medicare benefits. So there's a big question right now about what the super committee is going to do, because everything's on the table. They're trying to get $1.2 trillion in reductions. We work with a big coalition called the Leadership Council of Aging Organizations. There's 66 different groups, pretty much every national senior group in the country. We tried to pull together some principles for deficit reduction. I think we recognize that it's not whether we reduce the deficit, it's how. So some of the principles, some of which might be controversial, are trying to have shared sacrifice and a balanced approach that includes revenues, mandatory programs, and discretionary programs, trying to be balanced. As I mentioned with regard to NCOA, particularly concerned about the impact on vulnerable low-income individuals and seniors, trying not to force more people into poverty. And with regard to healthcare programs, where we recognize that they're increasing at a much more rapid rate than the rest of the economy, Medicare and Medicaid need to be on the table, but we think that the better way to do it is to look at how those costs are increasing and why the costs are increasing, rather than just requiring people to pay more, because they're paying more out of pocket already. One of our big focuses on the Medicare side is concerned about just shifting out-of-pocket costs onto them. One of the things that we've discovered in the One Away campaign is about 1 out of 3 seniors are economically insecure. Some of the facts that I mentioned earlier, the recession is hitting them pretty hard with regard to their investments and jobs. They haven't had a Social Security COLA for the past 2 years. And we can't forget that just last year, Medicare was cut by a net of $425 billion. Pretty historic reduction. So we got to be careful about what we do on Medicare this time around, and we're particularly concerned that costs for Medicare beneficiaries are already going up. Kaiser Family Foundation did an analysis that found, on average, in 1997, beneficiaries were paying about 12% of their income out of pocket, 19% now, and with no changes in the law, that's going to go up to 26%. And Medicare households spend 3 times more as a percentage of their income than non-Medicare households. So we've got to be really careful and precise about how we find savings in the Medicare program. We do have some real concerns about some of the ideas that are being tossed around right now. For example, the President has talked about increasing the Part B deductible, which is what you pay up front before you get physician services, imposing a new home health copayment, new surcharge on people that buy Medigap supplemental insurance, particularly those that have some kind of first dollar coverage, increasing the Medicare eligibility age. We could talk more about those, but those are some of the things that the super committee is looking at that we at NCOA and most other groups representing seniors have real concerns about. On the Medicaid front, Medicaid's a confusing program, and a lot of people don't understand how it works. They don't understand the stake that seniors have in the Medicaid program. It is a program for low-income individuals. About 15% of seniors rely on Medicaid for their health services, and seniors and people with disabilities are expensive. They're only about 1/4 of the people in the program, but they're 2/3 of the costs. So if we cut Medicaid, it probably will have a disproportionate impact on seniors and people with disabilities. The reason they cost a lot is because a lot of those Medicaid dollars go for long-term care. Nursing home care, which averages about $75,000 a year, home and community services as well. About 62% of long-term care costs in this country are paid for by Medicaid. So we're going to cut Medicaid. We need to recognize what impact that might have on some very vulnerable people. About almost 3 million getting home and community services under Medicaid, almost 2 million in nursing homes. Medicaid also, a lot of people don't understand, pays for Medicare premiums and cost sharing. So if you're below 100% of poverty, which for an individual senior is only about $10,000 or $11,000 per year, Medicaid is going to pay your Medicaid Medicaid pays for your Medicare premiums and cost sharing. And without that help, you wouldn't be able to afford it, and you wouldn't be able to get that service. So we need to be cautious. An area that we're very active on, and again, not a lot of people understand or know about, is the Older Americans Act. You know, people look at Social Security and Medicare and Medicaid and have a basic understanding, but very few people appreciate the range of services that are provided under the Older Americans Act, many of which are services that GRADD is involved with in one way or another. Looking at the list here, that really do help keep seniors healthy and economically secure and independent, and in our view, save money. We think that we're trying to collect better data to show that some of these community-based programs can save Medicare and Medicaid dollars by keeping people out of nursing homes, avoiding malnutrition, managing chronic health diseases. You know, a lot of people with multiple chronic conditions are very expensive. There are some evidence-based programs now to show that you can reduce hospitalizations and health utilization from some of those programs, and also getting seniors more engaged in their communities on a volunteer basis. This year, as my question earlier referred to, every 5 years, the Older Americans Act gets reauthorized. We think it's an opportunity to strengthen it, to modernize it, look to see what works, what doesn't work, make it more effective in serving seniors. There's a handout on the back table there about some of the priorities that we have. Number one being a greater focus on economic security, consistent with the One Away campaign that we're doing. We really think that the Older Americans Act can do more to bring together a variety of different services to foster economic security, particularly for vulnerable seniors. A lot of the debate in Congress right now is about appropriations and funding. The fiscal year 12 budget is being debated. Probably something's going to happen before the end of the year. A lot of these programs, again, are programs that GRADD is involved with. Workforce Investment Act, state health insurance assistance programs, AmeriCorps, community development block grants, housing, as well as programs under the Older Americans Act like caregiver support and nutrition, ADRCs, caregiver Meals on Wheels, etc. So what we're finding is the Senate has moved a bill through committee, probably not going to get to the floor before a compromise, some kind of deal is reached. On the House side, the subcommittee that has jurisdiction over the Older Americans Act, the chairman's put out a draft. It doesn't look like it's going to go through committee, but what's going to happen is, as usually is the case, you get the House leaders and the Senate leaders, and Representative Rogers is going to be one of the people in the room, try to find some middle ground and figure out what we can do to make this happen and fund Older Americans Act and other programs before the end of the year. Otherwise, we're just going to keep going with continuing resolutions, as they're known, which just extends funding for a few months. We're under a continuing resolution now, basically putting it off until we can agree on a bill. Some of the highlights, one of the good things we liked about the Senate bill, I mentioned chronic disease, $10 million for chronic disease self-management that we were very involved in, $10 million for falls prevention. It had only been $2 million. We got that increased. Huge issue with regard to falls prevention, cause of a lot of hip fractures and wrist fractures and head injuries. Costs our country $28 billion to treat them. We were spending only $2 million to prevent them, so we think that can save a lot of money. We were kind of disappointed that neither the House nor the Senate proposals have anything that the President had tried to get funded on a caregiver initiative, which would have provided funding for family caregiver support and supportive services. There was some elder abuse funding that we had hoped for that didn't happen. You may be concerned about the fact that the draft in the House largely eliminates the Corporation for National and Community Service, which includes the AmeriCorps program. So that's a fight that we're going to have to wage to try to keep AmeriCorps intact. We were very pleased, however, that the House, on a different subcommittee, restored some of the funding for elderly housing programs. It had been cut by almost half in FY11, and the House committee, in this case, Housing and Urban Development and Banking, restored about half that funding, so we're very pleased. Actually better in the House than in the Senate.